Hi, everyone, and welcome to our weekly UK Hangout through the Global P.A.D. Association. We have been sharing a series of interviews with incredible researchers across the UK. And today we are honored to have Dr. Chris Twine with us from Bristol in the United Kingdom, and he is going to be talking about some of the research that he has going on. It's been incredible to learn about all of the research opportunities for PAD patients, and we're just moving closer and closer towards a cure, right? No, we're hoping. But at least we know that there are people who care, there are doctors who care, there are researchers who care about PAD and are trying with all of their heart, all of their brilliance, all hands on deck, really trying to advance the care for PAD, because still currently there are still so many gaps, and not one treatment is completely durable except walking as medicine, right? But we have Dr. Christopher Twine. He and the team over in the NHS have supplied us at the Global PAD Association with many trials that are happening. We have them at padtrials.org. Make sure you check that out. We're adding new ones every single day. But thank you so much, Dr. Twine, for joining us. And at your request, I will try my hardest to call you Chris, but thank you for all you do to save life and limb.
Yeah, no problem. Thanks for having me.
So can you tell us just a little bit about yourself, a little bit about your practice? We joked beforehand why you have a foot fetish,
Yeah, yeah. So
why your
yeah.
interest in PAD.
Okay, so I'm a vascular surgeon in Bristol in the UK, and we do everything. But I've always had an interest in PAD clinically and research, and obviously it's our main problem at the moment. As the other diseases we treat are getting rarer, PAD and severe PAD is getting more and more common. So that's the reason that I, a few years ago, switched across to pretty much only doing PAD in my clinical practice, and my research practice is mainly based around that too.
Was there a defining moment where you said, I have to do this? Was there a patient that you were treating? Was there a series of patients in a short amount of time that led you to make this decision?
No, for me, it's just an obvious thing. As you're coming through, everyone used to talk about aneurysms a lot. Everyone was obsessed with aneurysms and their aneurysm practice. But actually, day to day, we were just dealing with legs all the time. And, you know, as you're training, sometimes you see people do that well, and sometimes you see people do it badly. And and so that's always been an interest of mine. And since I've been a consultant, it's been something that I've been interested in is the PAD side of things more than the aneurysm side.
What fascinates you most about PAD and the disease process itself?
I guess you can divide that into clinical and research, can't you? I think from a research point of view, to be blunt, we've got to work out better how to keep people alive with a leg, because I think we're really bad at it. And from a clinical point of view, I like the open operating and the endovascular operating for PAD. It can be technically quite difficult, so I find it quite rewarding.
I love so you take on the most complex cases,
Yeah,
trying to
we all
find a trying to find a needle in a haystack. Where's that one little crack in the plaque so I can slip my wire through?
maybe, yeah.
And so, to what extent do you exhaust all efforts to save legs? It's nice for people to know, what are some of the most advances that you have adopted in your practice in saving a limb? Do you go clear down into the pedal plantar loop in the foot? Do you treat the tibials? And what are the indications for
I think
for literally going the extra mile to save the leg?
So I think actually the biggest things that we do in our clinical practice is to get the system right for patients. So the problem is, by the time you are fiddling around the pedal loop or something like this, you're doing some ultradistal bypass, you are at a really late stage of disease. And I think that research has shown us in recent years that none of these things, whether when you compare one type of endovascular technique to another, none of them make a difference so long as you get blood flow back to the area you want to get blood flow back to, In some ways, it doesn't matter. In some ways, it does. But I think the big thing, what we've learned in recent years, is it's more important to recognise the disease and to treat it early. So you
Yep.
know, people recognise that people have got a limb-threatening condition and they get to us quickly, and we treat them quickly. That's been the biggest change in the last few years. It's not. There's no device, there's no stent, there's no lithotripsy or some complicated thing that's made any patient's lives better. It's all about actually getting people through, getting them recognised at an early stage, getting them through and treating them very aggressively, both from an interventional point of view and from a medical point of view, actually. But I think that's been the biggest change, and
Yeah.
that's actually one of the most important things we can do in a way. You know, I guess people will come on here and go, oh, I can do some amazing thing with open surgery, I can do some amazing thing with the wire. But actually, if they've just if they're working in a system where that limb threat's been recognised early, the patients come to them and they've treated them quickly within days or a couple of weeks, and then they've got all the medication right and they've treated them in an evidence-based way, that's going to do the most good for the most patients.
Well, I think for the long term, but we still have the CLI patients that have this newer type of disease, right? You have the traditional PAD, the textbook PAD that we called it, your grandparents' disease, right? I mean, it's, general older, um, former smoker, type of patient. And you ended up with the aorta, you have the iliacs, you have the common femoral, you have the superficial femoral, everything above the knee. And with that comes the textbook symptom of intermittent claudication. Wow, how are we not catching that early, right? But now you have this newer bottoms up disease that is prevalent in people with diabetes and chronic kidney disease, that they're asymptomatic. They don't present with your typical intermittent claudication in early stages. So how do you catch these patients early? It's just a matter of, testing everyone with who's at high risk, right?
I think it's also about recognition. So like as soon as they get a tiny ulcer, getting them to us at that point, yeah, not going, oh well, we'll put some dressings on that and then we'll ignore it for 6 months. I
Well, that
think,
too. Yeah,
yeah,
you're
it's very
correct.
difficult. It's very difficult, right? Because you're completely correct. It's much more difficult to treat PAD nowadays. It's not the smoker's disease that we used to treat a lot in 10, 20 years ago. It's very difficult though, because if you screen for PAD and intervene, the evidence shows that you probably do harm. So it's very difficult to know what to do. Maybe screening for it and giving medical therapy in these high risk groups is an interesting question. But really, what I mean is that when I say an early stage of the disease, I mean as soon as they start to get a problem. So let's say you've got your renal failure patient with diabetes with numb feet. As soon as they get that very small problem, then they come to us very quickly, rather than waiting or seeing other people. And that happens around the world, that then by the time they
Yep.
come to see the vascular surgeon, that the limb is so far gone that no matter what fancy technique you want
Yep.
to use with the wire, you're too late. So I think early recognition of disease is really, really important. However you do that in your healthcare system.
Well, there is so much. This is one of those diseases that there is so much control in the patient themselves. They have the power in so many ways to control their A1C and make sure their diet's in check, make sure they're walking and exercising as much as they can. That has been clinically proven to truly make a difference to stall
Yeah.
progression of
Yeah.
disease.
In claudicants especially. But yeah, you're right. People can treat themselves by looking after themselves, but sometimes it's very difficult, right? Some people have got very brittle diabetes, they have renal failure, they generally have very bad health. It can be very difficult to control these
That
things,
point.
you know.
Yeah.
Yeah.
That's why it's so good. I mean, if they're at high risk, if they are diagnosed with chronic kidney disease, if they are diagnosed with diabetes, to really double down on making sure that those risk factors are truly taken care of. So I imagine this seems to be something you're really passionate about, is you have multiple research projects you're working on, two in particular. Is one of them related to early testing potentially?
No, not mine. Mine are kind of late. So the big one that I've got going at the moment is for medical therapy after intervention. So if you've got limb-threatening ischemia, and if you've
Yeah.
had your endovascular perfusion done, someone clever's done that with a wire for you, and then what medication do you go on afterwards to thin your blood? Because we don't know really what the best what the best drug or combination of drugs is for people with chronic limb-threatening ischemia. So my trial that's running in the UK at the moment randomizes people to one of three treatments, which are the three treatments we use commonly: clopidogrel on its own, aspirin and clopidogrel, or aspirin and rivaroxaban, which everyone's on. Everyone's on one or a combination of those tablets after an intervention, but one of them may be better than the other, both in terms
Yeah.
of preventing problems, but also you've got to bear in mind that as soon as you put someone on something like aspirin, clopidogrel, you may be preventing cardiovascular problems, but you're also going to cause some life-threatening bleeds, and some people are going to die of that. So that balance is unknown. So the research is about trying to work out what's the best for preventing these events at the same time as hopefully not causing bleeding.
Why is there such a difference? And this is a loaded question. It's almost rhetorical, but why is there such a difference between we know what works for the heart, and
We,
you would think,
we
well, hey, if it works for the heart, it's the human superhighway. Why are these same methods not working for the legs?
So it's never been trialed. So in the heart, there have been loads of randomized trials, loads. There've been
Yeah.
like 20, 26. We've run one, and it wasn't us that ran it. It was a drug company to license a drug. So we're just hugely behind the cardiologists, basically. And what you've got to bear in mind is that our people with chronic limb-threatening ischemia, they've got a different risk balance to people having a coronary stent. So if you have your first heart attack or a bit of angina and a stent in your heart, your risk is much lower of having other things happen to you afterwards than patients
Yeah.
who've had a leg done for CLTI. They're much higher risk. So yeah, it's not the same. So yeah, it's basically, to answer your question, we've never looked at it. We've just been very slow as a community to do these trials, and this is the first one, if we can finish it, which actually looks at this in this really patient group that really need it. We really need to get it right.
Oh, it's critical. I mean, I see it. It's all over the place here. And we just had a question on what did it, I think it was yesterday or the day before. Nope, actually it was Sunday. Not that it matters. Where a patient in our network, Heinz, was asking, well, am I on Plavix for life after having a stent? I mean, I've been on it for years and I don't understand, why am I still on it? And then the doctor said, well, sometimes I prescribe it for 3 months, sometimes I prescribe it for 6 months, sometimes a year, and sometimes for life. And patients are so confused because they can't get a clear explanation from their doctors. Well, why am I, what should I be on and why am I on it?
That's because their doctors don't know. I mean, Plavix as a single therapy, you'll be on, people will be on forever generally, but adding things in and taking things away, we don't know. There's some guidance for it, but it's largely made up. And I can say that because there's a European guidelines document that I chaired a couple of years ago, and all of the evidence here, often it's just expert consensus because we don't have the trials. So
Yeah.
that's why it's so needed. And yeah, you're going to get that sort of unsurety from your doctor, and that's perfectly reasonable. It's because we've never done these trials. Whereas if you see a cardiologist, they can go, oh, you need this for 3 months, you need this for 6 months. They can be very sure because they've been through this process already.
And for those, we get this question a lot. I don't understand the difference between an antiplatelet, which is the aspirin, and the clopidogrel or Plavix, as they say some here, and the rivaroxaban, the anticoagulant. Would you mind explaining in layman's terms so our patients understand the difference between the two and why one is typically prescribed over the other?
Yeah, so the antiplatelet, so there's two ways that your blood clots itself. There's the platelets, which get activated and then start working, and then there's the clotting cascade, and those things are two separate things. They act together, but they're two separate things. So if you have an antiplatelet, it reduces your platelets' ability to bunch together and form a clot. So what that does in reality for your P.A.D is that it stops, or it tries to prevent thrombus forming in and around the narrowings that are already in the arteries. So you can think of it as it's a slightly weak way of thinning your blood. But the good thing about that is that it prevents these platelets clumping together, which causes these acute deteriorations in your leg, or it can cause your leg to go ischemic or your heart to have a heart attack or you to have a stroke. It reduces the risk of that happening by stopping them bunching together, the platelets. But at the same time, it doesn't cause too much bleeding. So because you're only affecting the platelets and not the coagulation cascade, in most people, it won't cause a problem with bleeding if they get cut or if something starts to bleed inside their body spontaneously. Rivaroxaban is an anticoagulant that you mentioned, and that we're using that a bit more in PAD now. Now, what that does is that blocks your clotting cascade. So that's a very strong way of stopping your blood clotting. So you are more likely to bleed if you're having an anticoagulant, say for a different reason, like atrial fibrillation, because your blood is very, very thin at that point in time. So there's a sort of sliding scale in between the two, like how thin do you make someone's blood for how much benefit, and they do slightly different things. So and rivaroxaban is new in PAD. That's that trial I mentioned that was done a few years ago by Bayer,
It's
who,
relative to the Voyager trial.
yeah, Voyager. But Voyager really had loads of claudicants having bypasses in it. So
Oh,
it didn't really have a huge number of patients with limb-threatening ischemia. And it didn't have a huge number of endovascular patients in it either in that group. So it wasn't brilliantly representative of it was it was helpful for knowing the broad group effect in PAD post-intervention, but you can't take Voyager and necessarily apply it to patients having an endovascular intervention for limb-threatening ischemia, which we do really commonly in real life in the UK, because in the UK we don't do much intervention for claudication, right? But there's quite a lot of it done in other countries like America.
I'm going to derail the conversation. I would love for you to explain because we get this question all the time. I don't understand. I'm in pain when I walk. You're telling me the solution is to walk through the pain, and that doesn't make sense to me. Why can't you just go in as an intermittent claudicant and just do a little roto rooting?
Yeah, I mean, and yeah, a lot of places offer that, right? So we've
I
got
have a
loads of
blockage.
yeah,
Why
yeah,
don't you treat
exactly.
the blockage? Isn't it going to get worse?
So intermittent claudication, we've
It's
got loads of
rhetorical, I
research.
know.
Oh, no, I get it, I get it. We've got loads of research in intermittent claudication. So I would say what I say to patients in the clinic, which is that claudication's a furring up or a narrowing of your arteries, and it's a life-limiting condition. It affects your quality of life. You can feel very isolated because you might have to stop every 50 steps, and your family don't have to, and your friends don't have to, and it's hard. But it's a safe condition, intermittent claudication. It's not dangerous to the leg. It's just an effect on your quality of life. So if you take 100 people with claudication, 75% well, 50% will improve, 25% will stay the same, 25% will slowly get worse. And of that 100, only 1 in 20 will actually develop a limb-threatening problem. Now, if you take someone with claudication and you clone them, so there's two identical people, and one of them, at the instant they come to you, you do them an endovascular intervention because it's normally a small blockage, and you put a stent in their leg. It's pretty easy to go through, and it works immediately for the claudication. And the other person, you just say, just walk at least half an hour, 3 times a week, and bring the pain on as much as you can. If you take that clone person, in 5 years' time, the person that you didn't intervene on is more likely to have a leg and is more likely to be walking a better distance. So that's the reason why intervention shouldn't be the first line thing to do. It should be about getting medical therapy right to reduce the risk of other things happening, and it should be about walking. Ideally, sending the person to a program to help them do that rather than just saying go away and walk, sending them to an exercise program so that people can show them what they should be doing. And actually, the other great thing about the exercise programs is you meet loads of other people with claudication and you start to normalize it a bit in your mind. But it's the same with the heart. For a long time, angina, people who were getting a bit of angina got a stent, right? And the cardiologists have realized that actually stenting everyone for angina causes more heart attacks down the line than if you just leave them, put them on tablets and exercise them gently. So walking does work. It is an evidence-based way of helping your claudication. It works really, really well. And in an ideal world, people shouldn't be intervening early for claudication.
It sucks sometimes,
It
to
does.
be
Yeah, it's
frank.
hard. Yeah,
It's not easy.
yeah, it's hard. It really reduces your quality of life. It's miserable to have it. And it's hard, I think, to go and hope that someone's going to do something for you and they say, you're better off walking and being left alone, because often you go in with this expectation, oh, why can't you just do a stent? but it's important, and I give people all the information. Intervention at that point that you first see them increases their lifetime amputation risk hugely. In the old trials, it took it from about 1% to somewhere between 6 and 8%. I mean, it's a huge increase in lifetime amputation risk doing something now, because people don't collateralize, they don't form those new arteries from walking and exercising. But yeah, if you want the lowest risk route for your leg, that's the best route. And I think having supervised exercise programs helps, because it helps you meet other people with the same condition, and it is very isolating, I think, having claudication. You won't really know anyone else with it. It'll just be you, and your family are all okay, and you feel bad because you slow down people and stuff, or you're a bit older, you want to spend time with grandkids, you can't do it. It's hard. It does reduce your quality of life.
But it's interesting that when we go to the gym and you're working with a trainer or you're working out with a friend, you're literally working out into the pain, right? You're pushing through the pain when you're doing your bicep curls. You're pushing through the pain when you're doing your deadlifts. You're pushing through the pain when you're doing the leg press. So how is it that people's thought process is different when they go out and they feel that same type of cramping, burning, and pain, and they're like, "Ooh, I better stop," versus in the gym, they're like, "Ooh, I'm going to push through that. I want the pain. I'm going to work out to the edge of that pain." And so
Yeah,
what we found, right,
it's
there's the
hard.
okay.
No, it's hard, isn't it? It's just hard. And you're right. You're looking at the same thing in two different ways. And I try and tell people, that if they were a professional athlete, they might run a marathon and then get this very bad cramping in their legs and then stop. But for them, that marathon's going to be 500 yards down a road, isn't it? But yeah, it is hard. It's psychologically hard. There's no doubt about it. It's a very isolating disease.
Yeah, it's why, and I a lot of my stuff is a little rhetorical, right? But I say these things because what we have found is that when we share with patients that, it hurts so good, it's just like when you're in your gym and it clicks for them. They're like, "Oh, I get it. I need to literally treat my walking workout as if I'm in the gym working with a trainer." And the trainer is saying, "Give me just one more rep." Well, instead, just give me one more step and one more step and
Yeah.
one more step. It hurts so good. And we have Kathy that is here as well. She's the one of the admins for our UK group, which if you're on Facebook, we need to get you to join because Thanos is on there as well.
I barely
And we
use
have
Facebook.
also,
Thanos
you
is
don't
very
use
good at
Facebook.
social. Not really. Thanos is very good at social media.
Is
I'm not.
very
I'm not
good
so
at
good.
it.
Yeah, he is.
But
Yeah.
you should have him, when you have your trials, things like that, and any updates, then give it to me or give it to Thanos and we'll stick it in the group. But also Kathy here is a patient, but also a big proponent. She's been on research advisory panels for walking as medicine over in Scotland. And she's saying, she loves our support group because we're there every single day with people outside of the clinic saying, "Hey, it hurts so good. Get out there and walk, walk, walk." And you meet other people that can encourage you every step of the way versus, 1 hour a day or 3 times 1 hour a week. We're there 24/7 giving that giving that support. And it's
I
really
think that's
helpful.
important. I think it's really helpful, and also it's interesting because we've done these randomized trials for claudication, which show that the going to exercise classes increases your quality of life. It increases your quality of life hugely, but it doesn't increase your walking distance hugely. So there's something else going on, right?
Whoa, that's interesting.
Yeah. So some people get really big gains, some people get very little gains, but they all get huge quality of life gains. So there's something else, and I'm sure, I mean, I think it's just an opinion that some of it is helping, meeting other people with the same condition, and talking about it and coming to terms with it and normalizing it. I'm sure that that's all as important as the exercise itself.
Oh, maybe we can do something together on that because
Maybe.
we just had a patient from the UK just do a 13K and improved his ABI from 0.6 to over 1,
I mean, that's incredible. That's
right?
that's what you want for everyone, right? Yeah, exactly.
Everyone.
Yeah.
We really believe it. We see it working every day. We don't see it working in some of the patients with diabetes and chronic kidney disease that are in more advanced stages that they do need a little bit of, manual restoration, right? Revascularization. But the thing is that at that point, is they need to walk, they need to push through, they're gonna need to get out and move. A lot of times, if they don't have a wound on their foot yet, but they're a toe step away from amputation, we talk to the doctor about getting the patient on at least a week, getting them on a regimented program, getting them to start walking beforehand, get them in the habit, get them on a schedule to start walking. So once they do get that blood flow restored, which is always temporary, that they're already on a schedule to be walking as soon as they can after the procedure.
Yeah, and as safely as they can. If they've got numb feet and diabetes, you need to do that carefully, right, and safely.
Yep,
But yeah, absolutely. That's yeah,
exactly.
that's perfect if you can do it for people.
And we have Kathy. She wants to jump in. Go ahead, Kathy.
Hi there, can you hear me?
We can
Yeah,
hear you.
Just the question on going to the gym and exercising. I have no access to walking groups, but I do have access to the local gym, and I go 3 times a week, and I do a kind of routine involving strength, build, squats, weights. But when I leave the gym, my legs are pain-free for a considerable amount of time. On the days I don't go to the gym, my legs hurt much more.
Oh,
And I realise that I'm just using my, my blood flow is increasing, but it's a noticeable effect. The same, I have to stop 3 times to go to the dance class. I can walk home without stopping. It's the same road. All I've done is do 40 minutes of attempting to dance. And I've been going on like this for 20 years.
oh,
So
okay.
it must be doing something.
Yeah,
And I think it's really, really important that we could try and get the message across to patients that it's painful. Yes, it sucks. Yes, it hurts. Yes, it's isolating, but it works because
mhm.
people want to get an intervention. I speak as a heart patient who's had a bypass, followed by a heart attack, followed by 2 stents not related to the
Yeah.
heart attack, but the artery they didn't bypass 29 years ago. But my angina was, even with the medication, was preventing me from even walking, whereas the stents have fixed it. So yes, there's a balancing act, but I just think there must be a lot more going on in terms of the ability to walk relating to other exercise that we are just not researching. That you're just saying to people, walk, 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 but they're miserable walking. I think we
yeah.
need to try and persuade people that there are other ways to get those legs feeling less painful. Does that make
That's a good
sense?
point.
It does make sense. And what you say is really interesting because so someone said this to me this afternoon, a patient in clinic said to me this afternoon, the day that I go, she works still and she's walking a lot at work. And she said, I have a good day, 2 good days after that. And then her son said, who was there, he said, yeah, but then you sit at home on your bum all day watching telly and then you complain about your legs. So it is interesting that you do hear exactly as you say that people say they have better days afterwards, which I guess is to do with just vasodilation from the gym. But your message is important that it does work, that being active does work, and that you basically in doing everything that you do, you're exercising the right muscle groups. What doesn't work very well are things like swimming, unfortunately, because unless you're exercising your leg muscles and bringing some of that pain on, you won't get that benefit.
And
Yes.
that's what we hear a lot is we hear from people that say that they, why can't I go walking in the water? It's because the whole idea, if you're dancing, if you're on a bike, if you're swimming and you are bringing on the claudication, right? As if you're at the gym. If you're bringing on the claudication, that means you're working through it, right? And that's the whole idea. That's what you want to do is bring on the claudication, work through it. That's when you're growing those collateral vessels. That's when you're dilating them and the angiogenesis, right? Takes hold.
Yep. Yep.
They really want people to, especially for people with wounds, the request we get a lot is, can you do more research on cycling and using foot cycles, especially for people who have wounds on their feet and they can't walk as much. Using the foot cycles not only for their vascular collateral improvement, but also cardiovascular as well, until the point where they can get their pace up to give themselves not only a vascular workout, but also a cardiovascular workout. Not sure if you've seen anything or anything might be underway with that.
We're not doing anything in the UK with it. I don't know of any research in that area in terms of wound healing or anything, but yeah, it's an interesting question. And people sometimes use various different devices which claim to stimulate blood flow, and it would be good to test them in proper trials.
One of the things I do like about the NHS and their program is they do have additional exercises, which they don't in some of the other programs I've seen around the world for supervised exercise therapy. You know, up on your tippy toes, down on your heels, pushing the
Yeah.
accelerator button forward, bringing it back. And so it shows a greater understanding, I think, there of other ways in which you can improve your circulation through isolated exercises that you can do while you're sitting or while you're just standing in the kitchen, holding onto the counter, brushing your teeth.
Yeah, exactly.
And Duncan has a question or a comment. Go ahead, Duncan, and then we'll get back to Kathy.
Yeah, can you hear me?
We
Yeah.
can.
Yeah, okay. So picking up on what Kathy said and also what Chris has just mentioned, my question relates to walking versus gym type exercises, because I've been diagnosed about a year with P.A.D and started off by doing probably about 50 miles a week. So that's 100,000 steps, let's say 5 miles a day, 3 walks a day, etc., etc. And I noticed a significant improvement through that. But I've for the last 6 months, I also go to the gym regularly and do classes. You know, basically circuit training and that type of thing, which also to some extent brings on the claudication. But I'm dropping off the walking by instead of doing, because I prefer to do the classes because of the social side, and I'm sort of concerned that I should be focusing just on walking rather than on doing weights and other leg exercise classes, which do, I get what you said, that perhaps cycling and swimming and things like that aren't as great, but a lot of classes which involve some sort of jumping or stepping and so forth do bring on claudication pain, and I guess that's just as valid as just walking, which is a bit boring.
So from an evidence-based point of view, most of our evidence is around walking because it's easy to do in a trial, basically. The key, Duncan, is exactly what you said. You need to bring the pain on. So whatever form of exercise you're doing, if it's not bringing the claudication pain on, you're not getting maximum benefit from it. And
Right.
I mean, you're like the dream patient, you know, you're so motivated, you're doing all this stuff. You're probably going to be fine whatever you do. But the key is that you need to bring the pain on. So cycling often doesn't bring it on. Swimming never brings it on. Whatever your classes are, if they're bringing the claudication on the same as walking does, then it's great. Go for it.
Yeah. I mean,
And we always
sometimes
say that if it improves, like if you're swimming and your walking improves because you're swimming, okay.
That's
But
great.
if it's not, then you got to do what improves your walking, which is walking.
So the
Swimming's
key is
got-
really to bring the pain on, isn't it?
Yes.
And
And
what
as
you
many
enjoy
times-
doing.
Yeah, and as many times as possible during the session. Just like Kim said about training, you know, do something until the pain comes on, then cut it back or stop, and then again and again and again in cycles, which is why when people lift weights, they do it in cycles. It's why when people train, professional athletes train, they do it in cycles, you know, sprint, less sprint, sprint, slow.
Yeah.
It's exactly the same thing that you're doing.
Okay, good. Thank you. That's helpful.
And we'll bring Kathy back in with one more, and then we'll get to your second study. Go ahead, Kathy.
Yeah, just on what Chris has said there, I find that the order in which they do the circuit training really matters. So if they do, say, 4 exercises in the trot, it's all legs. My legs have run out of steam by exercise 4. If they put weights in among it, so squats, lunges, lateral raises, farmer's lift, I can do the legs. I can even run in the gym. I can run 2 lengths of the gym, but then I
Yeah.
can't walk to put the bin out.
Yeah.
So, but I'm beginning to think that it's not enough for me now at 75, and with the balance issues and old lady muscle loss, I absolutely need to be doing real resistance exercises. And also I can't get the cardio benefit from walking because I cannot walk fast enough. So that's not enough to keep my stents, exactly as you say, to keep that collateral going that was there before the stents were in. There's a completely blocked artery that's entirely supplied by collateral. It's been blocked for 25 years. And they offered to open it, but I said no, for the reasons you said.
Yeah.
I had one heart attack that closed it. Leave it closed. I'm managing all right, but I need to be able to exercise to the right heart rate. So walking isn't going to do it. So I have to find a way to do it. And when I spoke to Kim about this, she said, but that's taken over your whole life. But yes, it does take over your whole life. So it's important to try and fit it in. And when I was working at home, I set up a workstation on my treadmill and I walked, typed, walked, stood up when I took phone calls, walked 5 miles a day while working. I think that's what's really saved my legs. I did it for a long time. And I'm a real proponent of people putting treadmills or walking pads in their houses so that they do it. Because although outside is lovely, you will do it on a treadmill watching a box set if you just get into the routine. And that's where I do most of my therapy walking, not outside where it's lonely and cold. I live in the Scottish Highlands, but it's lonely and isolating, as you say, and you're just stood by yourself in the sleet. It's not very nice. But I
Yeah,
just wanted to add that I'm beginning to think after all this time, it's important to build in other exercises, but walking is key.
If you can, it's brilliant. And as you say, working in the cycles is key. You know, if you're in a gym and they're doing it in a certain order, the order you want it is to exercise to the claudication and then maybe do something different. But I guess, you know, you're very advanced in what you're doing, Kathy. Both you and Duncan are very, maybe not representative of everyone with PAD, because you're just so good at what you're doing and you've done it for so long and to such a good degree. It's the reason you're still doing it, you know, and that it hasn't caught up with you again, because you're doing all the right, literally all the right things. You know, you could sit here as the expert and give an advanced class on how to exercise and balance these things. You could do it way better than any of us could as clinicians.
Yeah. And that's what we do every single day. And that's why we all get together every single week, is so that we can have everybody at every level to share their experiences and to motivate, because both Kathy and Duncan remember what it was like in the beginning. They're so good at expressing it. And they're like, you can get here. We even had Mike, the one that made it to the 13K. And that was just 6 months ago. He could barely even get out of bed. He was depressed. He had debilitating pain. And through our support, he really persevered, and we've been so proud of him. And it was amazing to see how quickly the ABI can improve. And once you can get that ABI improved, then you can start walking at a pace where you're getting both the vascular and cardiovascular workout. But we've even had doctors who have said, hey, I have a patient that's in cardio rehab, and because of their intermittent claudication, I can't give them the maximum benefit of cardio. So they may go in and like kiss the balloon in there, give them a little bit more blood flow to relieve the claudication so they can get the maximum cardiovascular benefit. Those are few and far between. But for the most part, it seems to be that you can literally improve your PAD really, really quickly. I mean, in a short amount of time, to a point where you can start to get that cardio up. And you could even do a hand cycle while you're sitting in front of the TV. So get your walking in and then do the cardio in front of your TV with a hand cycle, right? And then you bring up the good point. Resistance training is great too.
Yeah, some people can. It doesn't all. It works for most people, but there will be obviously some people where it's not as handy. I need to give you a quick like maybe 2-minute warning, because I'm gonna have to go and do bedtime in a minute for my son.
Oh, well, let's get to your other. Sorry, we get excited about walking as medicine. I know that's not what you expected, but it's like the #1 conversation that we have. So we get a little, off on that. But I want to get into your other trial. So tell us about your other trial that you're
Well, to be
involved in.
honest, the other trial we're doing at the moment is about pain relief after amputation. And I think that what we're talking about is much better than pain relief after amputation. But briefly, the other trial that we've got going from the group that I'm involved in at the moment is, if you do end up having an amputation for PAD or diabetes, we're looking at, some people put a catheter in the nerve at the time of surgery and put some local anaesthetic in that for a few days afterwards, and we're looking to see if that's any better than not doing that. But I think the conversation is better if we're talking about cardiovascular risk reduction, to be honest, than that trial specifically. Duncan's got
No,
his
but
hand up
that's
again.
really important. That is important, and it's great to know you're working on that, because that is one of the issues that we have. We have a lot of friends across the UK, United States, that have had the amputations and they still have pain, and then it's just this never-ending cycle. So seeing that there are other options being explored, that the doctors are listening and you are trying something, that's definitely something we want to know about and be able to share in our group if we see someone that does have the amputation.
Yeah, so amputation research has been almost nothing for years, and Dave Bosanquet in Cardiff is leading that, and he's really leaning hard into the amputation research to try and make things better for people undergoing amputation and who've had amputation. So you could talk to him about coming along as well. He's very good.
Yes, I would love it. If you can do an intro, that would be great.
Do that.
And again, for all these trials, make sure you go to padtrials.org. But we have one fun question that we ask every single doctor. So because it's not to mock patients. Patients just love the stories of hearing the lessons that, you know, they could learn along the way. But share the story of, you know, something a patient said, something a patient did was incredibly shocking for you, that you're still shaking your head to this day going, I can't believe they said that. I can't believe they did that. But you know what? It is what it is, and other people could learn from it. Um, I can give you a few examples, like diabetic patients stapling their socks to keep their socks up. We've had a dog eat a couple toes of someone with diabetic neuropathy.
Yeah, I've seen that. I guess the most shocking thing I saw a patient do with their leg was that this was a long time ago. They came in with a wound and it had maggots in it because of the way they'd been looking after it. And we made an offhand comment that maggots can be good for a wound, and we cleaned it all out and sent them home, and they came back and they just done it again because they thought it was the right thing to do. But yeah, that's probably the most shocking that I could say on here.
Do I really want to know where they got the maggots? Because I did have a patient's wife who told me.
Yeah, they got them from their bin. Yeah.
No. Yeah, we
Yeah.
had a patient's wife that was like, I am going to, if I can't get maggots, I'm going after roadkill. And I said, no, 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 no.
Yeah, it's a really
That
bad
is
idea.
no, do it in clinic. Talk to your doctor. Thank you so much, Dr. Twine. We really appreciate you. PADtrials.org if people want to learn more about those research opportunities and others across the UK. We would love to have you back, and any other introductions that you have with any other doctors doing great things in the UK that our patients need to know about, please, you know, create the introduction and we'll get them on as well.
I will. I'll email you and Dave. But thanks for having me. It's been great.
Thank you so much.
All right,
have a
bye-bye.
great
Thank
week,
you.
everyone.
Bye-bye.
Bye-bye.
Bye.